Right, well, welcome back, everyone. This is an exciting new venue for us. Well, from what I understand, not necessarily new. I think we were here like 100 years ago or so, but good to be back here in this cool ballroom. Being it's a ballroom, we all, as an optometry team, choreographed a dance. So if you guys all want to stand up, please, and oh, okay. I don't think you want to see that. Maybe Kate has a lot of dance training, so maybe we'll let her do it. But my wife and my wife Susie and maybe some optometry school classmates like Dave Turner have seen me dance, and y'all don't want to see that. So we'll just stand or sit. So our talk is post-op can't misses, which it just doesn't really roll off the tongue because that misses kind of seems a little bit more of like the feminine term, but really when we were trying to come up with a talk, something that we felt it would be educational for the group, really wanted to highlight some cases that patients that are out of surgery and oftentimes not necessarily in the early post-operative stage, but down the line. Some of these cases that come waltzing into your clinic and how you're going to deal with them, of course. Once they're in your chair, something that you have to be the point of contact. So we're going to go over some cases. Some of these are hypothetical cases, some of these are real cases. And hopefully you can come back with a little bit better understanding of how to handle some of these complex cases. So to introduce some of my esteemed colleagues here, so Dr. Patrick Schultz is one of our current optometry residents at Minnesota Eye Consultants. We have two residents coming from Appleton by way of Colorado and whatever, I don't know, he's kind of he's an Army brat, so he's been around, but also from Southern College of Optometry. Dr. Karina Bement is one of our staff optometrists. She was a resident last year, and we loved her so much and she loved us so much that she stuck around with us. So Karina practices out of our Crosstown and Bloomington offices. She does some specialty contact lens fittings at those locations as well. Dr. Kate Simcoe is our other optometry resident by way of Sioux Falls and ICO. And Dr. Jonna Hobbs is our Director of Optometric Services at Minnesota Eye Consultants, our fearless leader. She does a lot of dry eye consultations, and she's in Bloomington and Minnetonka. And I'm Mark Buboltz, so I'm our residency coordinator. I do, I guess, like a little bit of everything. Do a lot of dry eye consultations, specialty contact lenses. I'm out of our Woodbury office. And on the right there, just to kind of highlight, basically what do we do at Minnesota Eye Consultants? And I guess it's just kind of a little or a lot of everything. So we do a lot of co-management with our ophthalmology surgeons, whether it's cornea, glaucoma. We do some oculoplastic, some of those cases they keep in-house, but manage their follow-ups as well as post-operative care. Also do a lot of just general ocular disease and urgent care. As I know many of you have referred into our office, and usually we're the first touch point as you get into our clinics. So just to start to jump into some cases, we'll start with kind of a fairly simple one, but we're gonna kind of propose how this patient is coming into your clinic. So one day, SAS post cataract surgery. This is just a random fun fact, but I'm sure a lot of you have seen KPE, PCL, and have wondered why the heck don't we just call it cataract surgery? From what I understand, this goes way back to probably Dr. Lindstrom, our founders, but whenever we would write orders for the next follow-up, CE meant comprehensive exam, not cataract extraction. So we didn't use CE, we used KPE, PCL for Kepler, phaco emulsification, posterior chamber lens. So now you can take home something from today. So a few kind of stock photos. This patient comes in with, noting great improvement of vision, feels good, a little bit of foreign body sensation, a little bit of tearing. They're using their drops. I mean, we've all seen this patient a million times. But when we put some fluorescein in, look at the incision, we see that dark stream of aqueous that's displacing the fluorescein pattern. So sidal positive patient after cataract surgery, of course, the reason this is important is because they have a leaky eyeball, and if they're leaking fluid, their eye pressure can drop, they can have hypotony, they're at risk for endophthalmitis. So a few pearls here, for efficiency's sake. A lot of times these are fairly quick exams, but a lot of times what I like to do is put a drop of fluorescent even before I get the patient behind the slit lamp. Before I check pressure, I'll look at the incisions first, see if I can see sidal positive sign, and then I'll do Goldman tonometry. Of course, if you have a technician, checking pressure beforehand, I think it's still important that you put a little drop of fluorescein in to look at the incision as you're doing the exam. Listen to those buzzwords. Of course, there's nothing real telling, but foreign body sensation, tearing can be a hint that they are having that they have a sidal positive sign, and IOP can guide you. So, of course, lower IOP, higher chance of a wound leak. Most of these patients will be caught in surgery. After the surgery, the surgeon looks closely at the clear corneal incision to make sure that there's no leak. But sometimes, of course, they can slip through the cracks. So treatment mainstay is a bandaged contact lens. If it's really a brisk leak that you see on that day one, give us a call, and we should get them in the hands of a surgeon and probably put a suture in the incision. Ocular hypertensives, kind of counterintuitive, but if you slow aqueous production, you can slow aqueous through that incision and allow it to seal. But if you do put a BCL in, I think most of these patients really don't have to come back to us. Most of these patients you can handle yourself. You put a BCL in, obviously make sure they're using their drops, especially their antibiotics. Follow up in a couple, 2-3 days. The vast majority are sealed. If they're not, then let us know.
So this is a patient that came in 6 days after trabeculectomy in their left eye, complaining of blurred vision, pain, and shadowing peripherally. Their vision had declined from 20/40 to 2100. Eye pressure in the left eye was 4. They had no sidel sign. Their bleb was moderately elevated with a little bit of vascularization. They had 1.75 narrowing of the anterior chamber. So that's on a scale of 1 to 3, 1 being just peripheral iridocorneal touch, and then 2 is all the way full iridocorneal touch. So I just kind of grade it in between. So if I don't see them back for the next visit, someone else sees them, they kind of have an understanding of where in the cornea the iris had kind of been touching. And then 3 is obviously full lens touch the cornea. And then they had choroidal detachments as well. So if you haven't seen what a choroidal detachment looks like, this is kind of a serous choroidal detachment, kind of this yellowy gray appearance. It's just fluid behind the choroid. And then this is what it would look like on B-scan if you were to perform one of those as well. Hemorrhagic choroidals, which are more concerning, are typically filled in on B-scan here, and then more brownish appearance in fundoscopy. So treatment for hypotony after trabeculectomy when it's caused by no sidel sign. So in this case, it was an overfiltration, so just the trabeculectomy was working too well. Your mainstay treatment for hypotony is going to be atropine. So it's just going to rotate the ciliary body posteriorly, which pulls everything back, which helps deepen the anterior chamber and helps reform the anatomy inside the eye. You can manipulate their steroids depending on where they're at and what kind of procedure they had done. So if they are hypotenuse and it's because the ciliary body is shut down because they have a lot of inflammation, then you increase the steroid. You could increase the steroid to try to develop some sort of a steroid response to elevate the pressure as well. And anti-hypertensive medications, it depends on the procedure, but if they had a trab, they'll probably be off of everything. But if they're not, then just kind of take them off of some of those antihypertensive drops to help the pressure come back up. Since there's no Seidel sign and they're hypotenuse, you wouldn't add any back to try to seal the leak because there's none. And then viscoelastic. So in this case where they have this narrowing of their anterior chamber, depending on how significant it is and how it responds to therapy, they could require a viscoelastic injection. But this patient didn't. They responded well to the atropine. It pulled everything back, so they didn't need to have any viscoelastic injected. And then always have them wear an eye shield at night to protect the eye while they're sleeping. And this is just kind of the hypotony checklist that I do when I'm looking at a patient that's hypotenuse. Is check their pressure with Goldman. Look for leaks over any incisions that they've had or over their blebs if they've had a trabeculectomy or other kind of new drainage procedures. Evaluate for trauma, signs of trauma. They could have a cyclodialysis cleft. You can actually create a cyclodialysis cleft during surgery as well, so sometimes that is a cause for hypotony. Atropine treats that as well. It pushes everything backwards and kind of helps close up that cleft. And then check for signs of intraocular inflammation, assess the integrity of the anterior chamber. If you can't get a view into the posterior pole, use B-scan or UBM. And then just initiate treatment targeted at treating what they have going on.
I wonder if we can come back to that though. How's a patient like this tend to present? Because I feel like, a lot of times they're going to be unwell feeling and actually a fair amount of pain. How might you tell the patient, we talk about using a shield, do you provide any other instruction for them?
Yeah, so they do often present with pain. If you look in textbooks, it usually associates pain with hemorrhagic choroidals, but almost all the serous choroidals I've had come in have presented because they've been in quite a significant amount of pain. But they respond really well with atropine, so it typically does a really good job of kind of decreasing the pain fairly quickly for them. So I usually put a drop in office for them and they start feeling better fairly soon after that.
Yeah, I find that telling them to, when they're sleeping, to not lay all the way flat is also pretty helpful in reducing their activities even more so, which they're happy to do because they're not feeling so well.
And this is a case is a real patient of Patrick's. Patrick has kind of become our hypotony specialist at Minnesota. So if you have hypotony, send it to Patrick. He's seen a good dozen or so of these. But I guess, just, in general, any patient that has a filtering device or trab can develop hypotony even down the road. So, these patients, may be coming in a year after their trab, something to be on the lookout for. I guess anything to speak on how you, of course, with the chief complaint of dark shadowing peripheral vision, obviously kind of the first thing that we all think of is retinal detachment. I guess, do you have any pearls on what you're looking for in deciphering, just kind of based on their symptoms of, what type of exam techniques you're using to look at the back of the eye and decipher, is it choroidal effusion or a retinal detachment? Because they can look somewhat similar.
Yeah, I always dilate these patients just based off their chief complaint. But it's, when you look into the back of the eye, if it's a detachment, you'll have that kind of wispy, clear, whitish appearance. Choroidals are significantly different in appearance. You can really appreciate the elevation coming forward. And sometimes, depending on how large they are, you pull back with a 90 and you'll see them pushed forward towards the posterior pole. So if you've seen a lot of detachments, it doesn't look like a detachment, or retinal detachment.
Yeah, good. And the other concern is the kissing choroidals, I guess part of it. So you can see in this B scan where the choroids, starting to get fairly close, but you should be able to still see back to the macula there in this B scan. But as they're getting close, you obviously don't want both sides to kiss or touch. So even more concern for getting their pressure up somehow, whether it's a viscoelastic injection or seeing like a retinal specialist.
This next case is an 83-year-old female patient, new patient from out of state. She presented to our clinic stating that she woke up in the middle of the night with 10 out of 10 pain in her right eye, and the vision in that eye went completely black. She said it felt like it was starting to become infected the day before. She has glaucoma, kind of a murky history, but trabeculectomy in the right eye and tube shunt in the left eye, and she's currently only using topical medications in the left eye. Slit lamp findings here, a few things to call out. Vision in the right eye was NLP, after that previously being her only functional eye. IOP in that eye was 58, flat bleb, a positive Seidel sign, inflammation in the cornea, and then a 1 millimeter hypopyon in the anterior chamber. So lots of signs of infection and inflammation. For this reason, we urgently sent her over to a retina specialist where they performed tap/injection and culture of the anterior chamber. Luckily, we were able to get her in about an hour after we saw her, so she was seen fairly quickly. We also started her on topical antibiotics every hour and encouraged her to use them throughout the night as well. Had her start all of her glaucoma medications in the right eye instead of just using them in the left eye, and then follow up with a glaucoma specialist at our practice the next day. So we made the diagnosis of blebitis or bleb-related endophthalmitis for this patient. A few things just to remember with a bleb is that a bleb-related infection can occur at any point after a glaucoma filtering procedure. So days, weeks, months, years after, you should always be evaluating that bleb. If a patient calls with concerns of a red eye, eyes feeling infected, irritated, anything like that, and they've had one of those glaucoma filtering procedures, you should treat it as an urgent issue. It's important in these patients to always check the Seidel sign and evaluate the blebs, so putting fluorescein, having the patient look down. Usually those blebs are superior temporal, but sometimes they're inferior as well, so if you're not seeing it, you may need to look around. And then right here, you can see this is a pretty typical appearance of that white on red blebitis in the acute phase. So the white avascular bleb with the hyperemic conge surrounding it is usually a pretty good clue that the patient does have blebitis. And then here you can see the avascular bleb, and it has a cystic appearance, and then you can see the fluorescein pattern, how it kind of pools, shows that that patient does have a wound leak.
Yeah, this is a patient that Kate and I saw together. I think that the referral note, or at least the notes in the system, were they were referred for angle closure. So I think that remark on, and we'll talk about it on another slide too, but have the patient look down and look underneath their lid. I don't think that the referring provider knew that they even had a trabeculectomy present. We saw pressure of 58 and an angry eye, and unfortunately for this patient, basically it kind of seems like nothing could have been done anyway. They had a very aggressive infection and ended up losing the eye, but it was something that could have been life-threatening with how quickly it was spreading. And as Kate alluded to, it was her much better eye, her other eye's hand motion, so it's a very unfortunate case for that patient. All right. This is me. So 78-year-old patient. This is a hypothetical one, but she comes to your clinic and wants a full exam with a glaucoma check. She complains of a little bit of foreign body sensation, a little bit of epiphora, vision's pretty stable, wears soft contact lenses occasionally. This patient is, this type of complaint is something we see all day, every day. Has a history of glaucoma. She had some sort of glaucoma surgery 6 years ago. Can't remember exactly what it was. Eye pressure is overall good, 16 and 18, using latanoprost in the left eye. So this is how she presents. She is Mrs. Potato Head, and she's kind of a makeshift nose and eye, but so her right eye here, you can see, looks sort of like a dry eye, definitely more injected there on the right side, or the temporal kind of aspect. But, if you look underneath the lid, you see this. So there's a lot of movement, a lot of education for doctors to look down because of, making sure that we're looking for Demodex blepharitis, which some pharmaceutical companies are really hammering home. But look down and look under the lid, I think, is important. Catching so many things under the lid, other than glaucoma stuff, SLK, GPC. So to name a lot, so take the time to thoroughly examine the ocular surface and under the lid. So this is a exposed tube shunt. Of course, the reason this is important is because if that tube shunt's exposed, you got direct communication into the anterior chamber. Bacteria can follow that little tube and get into the eye, and then we're in big trouble. So tube shunts, it's not completely abnormal for these tube shunts to become exposed. In a giant study, the Traverse tube study, it was known that 5% of tubes had erosion at some point. I feel like that seems pretty high, but it was a big study. I can't remember what the sample size was. Making sure that you're checking around the tube if it is exposed, if there's purulence, or essentially if you see kind of white blood cell, any sort of like infiltrate looking appearance to it, to hint that there might be an infection starting. Also looking at the anterior chamber, is there any cell present, especially if it's getting pretty significant? That's a hint of early endophthalmitis, or especially if they're starting to show some cell in the vitreous, they need to get to a retinal specialist urgently or immediately. If you do see this, this is something that definitely deserves urgent referral back to us, specifically to one of our glaucoma surgeons. They'll need a tube revision or a conjunctival advancement over the tube to cover it back up, hopefully within a few days. In the meantime, as they're getting back in with us, make sure that you do start them on an antibiotic pretty aggressively, probably every hour with a drop like moxifloxacin. And also provide some lubrication too, just for their comfort, but the main thing is making sure they don't get infected. Anything to add to that? Wow, I covered everything.
Was it me? You're looking.
No, I don't know. I was just saying I covered everything. Nice.
You did good.
All right. Another case. Patient walks in, increased redness of the eye, mild pain, photophobia, vision slowly worsening over the last few days. History of keratoconus, history of corneal transplant. As you can see by this picture, not looking completely normal. Used to be using a drop with a pink top. Hasn't used it in a while because he hasn't had follow-up in about 3 years, so stopped maybe about 3 months ago or so. Vision is 2100 out of that eye, and the other eye is about 20/20. So fairly obvious here that we're dealing with a case of corneal transplant rejection. So, treatment for this type of patient is we do want to get on a steroid quite aggressively to fight that rejection, so it doesn't ultimately lead to failure. Of course, there's a big difference between rejection and failure. So most rejection episodes we can get control of. So consider, even nighttime dosing, having them set an alarm, or use an ointment like a lodiprednol ointment for overnight coverage. Use a cycloplegic, especially if they're light sensitive or if they have a significant anterior chamber reaction. You do want to see back, follow these patients really closely, see every day or two until you really solidify that they are getting better. So some considerations are, of course, what is causing rejection of this patient, or patients in general that have corneal transplant. It's all around inflammation. So what contributes to inflammation? Things like loose or exposed sutures, which we'll get into in a moment too, but any sort of friction or irritation on the surface of the cornea promotes inflammation, and that promotes things like antigen-presenting cells that are going to identify that cornea is foreign and cause the rejection episode. If they're in contact lenses, of course, a lot of these patients are in RGPs or sclerals. We do need to be mindful, especially with this type of patient that I'm fitting in sclerals, really want to be mindful of that sagittal depth. In sclerals, a lot of times you're looking for a specific amount of vault. With these, I want to try to go as low as possible while still maintaining some vault, because that that saline layer does have a fairly low decay value, and so there's much less oxygen getting through that saline layer. If the lens is too tight, if it's a poor decay over T material, is also something to consider. And neovascularization, which is one of or actually the highest risk for corneal transplant rejection. You can see this patient has quite a bit of neovascularization right up to that graft edge, and so that neovascularization is really going to cause a high risk for rejection. Don't freak out. These patients can be scary. They have a drop in vision. They've got a red, angry eye. But if you treat aggressively, even the most severe cases, 60% of them will turn around on topical therapy alone. Some may require sub-T non-triamcinolone or even oral prednisone. So if they're not responding initially to your topical therapy, make sure you send back to one of our corneal surgeons. Regardless of if they are regardless of if you're going to try to treat in-house or not, we definitely want to be kept in the loop as far as how things are going. So making sure you, at the very least, send a note back to us, call us, and let us know what you're handling so we can help guide you. And I guess another important note is before you're hammering them with steroids, making sure you're checking for dendrites. So some of these patients have a corneal transplant in the first place because they had herpes simplex keratitis. And so if you're missing a dendrite, you're hammering it with a steroid, that's obviously not gonna benefit the patient. So if they have a dendrite, got to make sure that you treat with your antivirals first before you really ramp up that steroid. So what else are we looking for besides a edematous cornea? So limbal engorgement, so a lot of injection right around the limbus. Do they have an anterior chamber reaction? Do they have keratotic precipitates? Cataduce line is pathognomonic for endothelial rejection, where you get this kind of line of white blood cells in a certain section of the cornea on the endothelium, and you'll get overlying stromal edema. Rejection rates, basically the thicker the tissue, the more likely you are to reject. So penetrating keratoplasty, 20% overall had a episode of rejection at some point in his life. So that's pretty high, 1 in 5 PK patients, and that's 35 plus in high risk cases. So something that we see a lot, and again, most of the time our optometry team is able to kind of quell that rejection without having to deal with a failure and repeat transplant. DALK is more of the 6 to 19%, DSEC is 10%, and DMEC is about 2%. So of course, that real thin tissue of a DMEC, much less risk of rejection.
I have a question for my own also, because I don't fit the scleral lenses. So a lot of these patients can only really see well if they have their lenses, but if we're hammering them hard with the steroid, do y'all leave the lens on? Do they get to wear the lens? Do they have to take a break? I see Karina.
Karina, I'll let you.
I have them take a holiday from their scleral lens until we can reduce the dosage on the steroid, just for better absorption.
I think that's me. Thank you. Okay. So sometimes these can't be saved. We have to repeat them. And this is a case of a patient who I think is an actual patient, as I recall. Sometimes they get a little muddy. There's a BCL placement on the lens due to a likely epi defect from these folks. They generally will have an air bubble. So if you're seeing somebody like in your clinic, kind of looking at the size of the air bubble, this would have been taken on day 1. where you've got still a pretty good air bubble there to work with. And of course, when we're dealing with a DSEC or a DMAC, they need that air bubble, and they have significant head positioning, and they don't like it. So you got to really kind of goad them into kind of doing their head positioning. And my personal, I know that some of the surgeons try to kind of just do it when it's really super effective, but I figure if you've got a bubble, let's use it. The repositioning of the graft, 360 degrees with central attachment is kind of what you're looking for. So you're checking all the quadrants, you're checking to make sure that the center of the graft is up against the back end of the cornea, and sometimes that can be tough to see when you've got the bubble in the way, but you kind of get used to using kind of a diffuse and then kind of like making your slit a little bit smaller. Also tend to look for an iris PI, make sure that it's patent, and you're also looking for a normal IOP, although obviously it's going to be done through a lens. So these are instances where it's not quite perfect, and each of them, of course, this is kind of tough because they're using slit images, which are a little bit difficult to see. You can, obviously, the kind of the upper right is pretty obvious where it's just simply not where it's supposed to be, and that's something that sometimes will resolve itself if you got good touch surround, but you'll also have these areas where it looks a little bit folded. So that lower right corner where it's just kind of like, boop, kind of like picked up at the edge, those, quite honestly, are kind of left alone, and we just monitor those unless you have a lot of edema in the area. Once it's dislocated and rebubbled, this is another patient, a 60-year-old patient who complains of hazy vision. She came in about a week after her procedure, kind of an uncommon time. We see them at one day, like 3 to 4 days, because we're looking for these things to be true or not true so that we can take them back to the OR if we need to. Well, not me, but kind of like figure out like where the surgeon's at. You're really checking to make sure that the pressure is stable. This is going to tell you a lot of information about the status of the graft, and if it's really high, it will throw a lot of swelling into the cornea. It'll end up like it's looking like it's rejecting, but it's too early really for that to be happening. When you've got just a tiny little bubble remaining, like you can see in the upper left-hand picture, and to be honest with you, I don't know why that eye is bleeding, but the upper right hand kind of shows a really nice little elevation, or little bubble there at the top. Obviously, this patient's out. If you're seeing this on day 1, that bubble is too small, and they probably need to have a rebubble. If you're seeing that patient on day 3 or 4, well, that's kind of normal. So you're kind of looking for a gentle decrease of the bubble to kind of indicate that things are coming along pretty smoothly. The lower image, the OCT images, I think is really telling where it's just not going to touch. There's no way for it to clear that cornea, bless you, if it's not touching the back edge.
And this might be obvious, maybe not, but once the graft is deemed attached and the cornea clears, say 6 months down the road, the patient comes in with edematous cornea again, it's not the graft detaching. So once the cornea is attached and is working, it's not going to just spontaneously detach on its own. So if this type of patient is coming to your clinic, most of these early post-ops are handled at our clinic, but once they get back out to you, if they are showing signs of edema, it's probably either rejection or failure of the graft.
Exactly. Oh.
All right, case number 7 is a patient that calls into your office a little bit more than 1 week post-op from ALKRS and cross-linking. This patient had no-showed their 1 week visit for a bandage contact lens removal.
Classic.
Naughty, don't do that. Their symptoms were concerning, Increasing pain, discharge, eye was glued shut in the morning, getting a little bit worse every day, very uncomfortable. The entering vision in the surgical eye was 2200, and pinhole no improvement. And as you can see from the photo, that is a pretty juicy looking cornea. There's a lot of swelling, there's still a large epi defect, and at 1 week we would want that to be gone. Also quite a bit of infiltrate.
And I guess maybe just to clarify, this is a real case and a neat case, but I think all of this is something that will apply to any of the corneal epithelial removal techniques. So cross-linking, PRK, anything there. So I think as far as like applicability, this is a very unique case, but not as unique for any of the ones that you co-manage as far as PRK and cross-linking.
Yeah, thank you. That kind of ties into the incidence rate. So for cross-linking, it's super low chance this will happen, 0.71%. For epi-off procedures in general as a whole, it's even lower than that, 0.04%. So pretty uncommon, but super scary when it happens. Really important to know when you need to get your patients in. So kind of timeline is key on determining, is this a normal post-op complication? As far as symptoms, like on day 2 and 3 for an epi-off procedure, we expect our patients to say their eye is really uncomfortable. It's maybe even a little bit worse than day 1. It's going to be light sensitive. The vision might be worse before it's better. But if you have a patient calling you on day 4 through 8 and they have worsening symptoms and those symptoms are new, maybe, that patient needs to be in your chair that day. So this patient was cultured immediately. Obviously the patient's on an antibiotic, so if you don't have culture ability, send it back to the surgeon's office for culture. Again, if you don't have fortified antibiotic options, just increase the drop that they have in the interim. It's really important to get as much antibiotic on as possible. If there's any hint of fungus, if you have the ability, you could do a fortified voriconazole, or if there's any suspicion of antiviral, it doesn't hurt to add Valtrex as well.
I think this one's mine. Thank you. Yeah, and something else that I'll say about that, you kind of glossed over it, is that epi defects really should be closed at 1 week. And if they're not, there's got to be a good reason for why. In a lot of cases, these patients who have had ALKRS, those contact lenses actually don't sit on their eye very well. We usually use AccuView therapeutic, and they tend to slip off. And patients will say, yeah, I lost my contact lens, that's why I'm not coming in. Well, did you actually see the lens come out of your eye? Because if you didn't, you need to look for that lens. It could still be up there. That's what happened to me too. So, yeah.
And to clarify, I'm sure Dr. Harden will talk about ALKRS later, but ALKRS is a keratoconus technique similar to when we used to use Intac, but instead we're using donor corneal stroma to do that little boost of the cone. So again, we'll get into that more later, I'm sure.
Thanks, Mark. So, all right, so case number 8, 58-year-old female. She's 4 days after her LAL, light adjustable lens. And I will preface this by saying we don't see patients on day 4. So you'd think that like, oh, this is just should be obvious, except it wasn't to me at the time. And without my colleagues, I could have missed something. So I wanted to let everybody learn from an initial flub that I made. She called at 11 o'clock to the clinic saying that she was driving to work and she had a sudden shower of black dots and spots. And she wasn't having any pain. And of course, what do we all think? Oh, she may have had a retinal detachment. So guess what day this is? It's a Friday. And she says she's looking through, looks like she's looking through a veil or a screen, but she's overall seeing pretty well. So our triage department did exactly what they should do, and they got her in with me at 2 o'clock, and by 2 o'clock her vision was 20/40. She had been 20/20 on the first day. And she says to me, I haven't really been using my drops correctly. Everything's been going so well, I didn't think I needed them. So with horror striking my face, I take a look at everything and I look inside her eye, and she's just got a really prominent AC reaction. And it's actually got some fibrin in the pupil. And of course, it's day 4, and I think, well, this could be anything. Maybe there is a retinal detachment. I got to rule out all the things. So this is the pictures that we took, the OCT. And one of the things that you can see, and I don't have a little thingy here, but one of the things you can see on the left eye is just a bunch of garbage in the vitreous. And that's should have been when I knew what was going on, but I didn't yet. She had endophthalmitis, and this is exactly how it was presenting. I talked to the retina specialist and I said, this is what I'm seeing, this is what I think we should do. By this point, she'd already left. I'm speaking to retina around maybe 4 o'clock in the afternoon, and he says, well, we'll see her in the morning, early, 6:45. And by 6:45 the next morning, she was hand motion. She had a hypopyon, which she hadn't had when I saw her, which would, of course, would have struck me in the middle of the forehead. She ended up having a guarded prognosis, AC washout, all the things, intravitreal antibiotics. And about a week later, I believe she saw Dr. Buboltz, and she was 20/50. Yay. So I'm thinking this is like, great, awesome. I just heard back from retina last week on Thursday. She's back down to 2100, and she has a new ERM, which they're going to attempt to repair. So this is all in the face of an LAL, which of course is very regrettable that it should happen at all. I think that being able to identify these patients as being emergency patients right from the very beginning, and to think of all the things rather than the thing that it's most likely, you always have to put the most likely as being the worst case scenario as well. As it turns out, her admission that she wasn't using her drops all that frequently probably had nothing to do with it, but nonetheless, she's using her drops now. Well, maybe not now. So just kind of like harkening back to the mid-90s, the endophthalmitis vitrectomy study, most people will present with blurred vision, and in most cases, about 80% of the time, you're gonna have a red eye. Her eye was white and quiet. Most of them will have pain. She happened to be one of the 15%, or one of the 25% that did not. About a third of them will have a swollen lid. Nope, she looked great. They tend to have epiphora, photophobia, all the things like that, and a hypopyon. But this is all dependent on when you see them. When you're seeing it as it's emerging, which is exactly when you have the right time to do something about it, not all of these things may be true. But the one thing that is really diagnostic is going to be the copious amounts of cell, fibrin, and, like I like to call it, garbage everywhere on the inside of the eye. So you do need to check for an RD, and look so that you can differentiate an RD from vitritis. And these folks tend to present 3 to 5 days post-op. That's when an infection is generally going to take hold. This is differentiated from TAS, which happens more immediately, more of an inflammatory reaction to something, whether it's a preservative or contaminated BSS, endotoxins from bacteria due to kind of the sterilization process of our instruments. But the thing about TAS is that we probably don't see some of those folks unless it's a really prominent reaction, because most of them are taken care of just with the treatments that we give them already, our pred and our antibiotics. So this is kind of one of the reasons why we really hammer down taking their drops and understanding what they're using so that they understand why. They're going to present a little bit differently as far as timing goes. TAS is much, much earlier, and endophthalmitis is a little bit later, kind of up to that 7-day period. But they're going to be equally kind of important. So just kind of a mention of the fact that we always have to be kind of on the lookout And be wary of working on Friday afternoon.
All right, so next case, a patient coming in complaining of foreign body sensation for the last week, some mild tearing, notable history of keratoconus, and a history of a corneal transplant. On presentation, you can see a picture looking like this. Looks like a pretty normal PK graft, a pretty normal corneal transplant. Maybe something that you start to think, yeah, they probably just have dry eye. We'll be treating their dry eye. But importantly, we put some fluorescein in, and you see this. So you pick up some stain around some of the sutures. Of course, this is important to catch and to treat, because if you have some stain picked up, you basically have a little epithelial defect, and with an epithelial defect, now you're concerned for corneal infectious keratitis or rejection of the transplant. So something that you really want to treat. If the suture is broken, something that we all should be comfortable with, grabbing a jeweler's forceps and taking that suture out. Don't wait to have it removed, or try not to send it back to us to do it. Just try to do it yourself and get it taken care of right away. If it's loose, that's where I know maybe a little bit more kind of on the edge as far as your comfort level as far as removing. If it is loose, we do definitely want to have it removed, because that does increase the risk, again, of infection or rejection. So a little schematic there as far as cutting the suture. You probably have some sort of needle, tuberculin needle in your office. Usually we use about a 26 gauge needle. But the idea is you're going to go underneath the suture, bevel down, twist the needle 90 degrees, so now you have that cutting edge of the needle, and you lift up. And when you lift up, sometimes it takes a couple times, but the suture will break, and then you can grab that edge of it. You try to cut away from where the knot is, because if you cut closer to the knot, then when you have the long tail on, say in this case on the right side, then you're going to pull that knot all the way through the cornea. More likely that you're going to just have a partial suture that comes out. If I can, there's a video, but let's see if I, oh yeah. So here's a little video of this is just a suture after cataract surgery. So really want to make sure that the patient is fixated on something. Tell them not to look. I'm sometimes worried about telling them that I'm going to use a needle in their eye. Sometimes they'll say a probe or something like that. But and having really good lid control as well is key. So there's a good chance that they're going to blink at some point. So make sure you have a good grasp on the lid with your fingers, or even using a speculum. So there you can see, real quick, got underneath, twisted it, broke the suture. Go back in with the jeweler's forceps, and you want to go fairly quickly when you remove it. You don't want to just kind of diddle-daddle and slowly pull it out. So once you got it, commit to it and pull it, and should come out pretty cleanly, just like that. What do you think, Patrick? I took that video.
Oh, wow.
Did you really?
Yeah.
Awesome.
What cinematography?
That, by the way, was actually, I think, a post-op for cataract, yeah?
Yeah.
So the suture is through the main incision site up above. Our surgeons are so nice to us that they put it up above so that you just have the patient look down. You give them something to look at, because inevitably they will look all over the place, and then that's right where you've got your forcep, which makes you very uncomfortable and a little hot. But after you've done a few of them, you kind of get the hang of it.
Yeah, so regardless of if you do remove the suture or not, definitely want you at least covering with an antibiotic, of course. Don't just lubricate. Make sure you give some prophylactic antibiotic to make sure they don't get an infection. And then they should get back in with us at least within a few days if they do need suture removal. Go ahead, case number 10.
Case number 10 is a patient that comes to your office for just a standard one-day cataract post-op. They have pain, about a 6 out of 10, a little bit of surface irritation and a mild headache. Vision in the surgical eye is 2400, pinholes to 2200, and pressure in the surgical eye is 37. So the photo maybe doesn't look too abnormal on first appearance. The cornea is pretty cloudy, depending on the density of the cataract, that can be common. But you might also notice that there's a little shadow happening. That's a retained lens fragment, and that's a pretty good chunk there. So one of the more common complications after cataract surgery, totally manageable, 0.1 to 1.5% of patients will have this. There is a kind of distinction that you need to make when you're deciding if you're going to treat it in your office or send it back to the surgeon. A cortical fragment, if it's small enough, is totally dissolvable, something you can absolutely manage on your own. If it's nuclear, it definitely needs to go back because the immune response to a nuclear fragment is pretty severe. So the cornea will be very cloudy and the eye will be uncomfortable. If you choose to monitor the fragment in your office, you're going to see this patient back maybe every 4 to 5 days initially, make sure that their inflammation is improving, that the pressure is lowering. You'll be able to get a little bit better view of the lens fragment if the inflammation comes down. So you're probably, for this patient, you're increasing the amount of steroid that's going in the eye to every 1 to 2 hours, and then adding a topical pressure lowering. This fragment, just on a side note, was large enough that it did have to be washed out. So this was done on a Thursday and washed out on a Monday, just because it was just on the cusp of being a little too big. If there is a posterior fragment, then you definitely want to consider sending that patient off to retina for pars plana vitrectomy, especially if the pressure is not controllable. A couple more examples of some variations in size. So the picture on the left are very small fragments. I don't even know if you can see them on the screen, but just little tiny flecks of cortical that will dissolve really easily just with standard post-op drops. Nothing special there. Photo on the right is a little bit larger of a fragment, still totally dissolvable. That patient just needed a little bit of extra steroid. Within a month, that fragment was gone, something you can totally manage in your office if you're comfortable with it. Biggest kind of key takeaway is keep in mind the patient's vision. Is the vision getting better? Is the inflammation getting better? Is the pressure stable? If you're okay on all those fronts, it's okay to monitor. Anything longer than a month, though, if there's still a piece there, send it back to the surgeon. That will likely need a washout. Case number 11, this patient calls you 7 weeks after they had cataract surgery with new blurred vision, a little bit of distortion, and a little bit of light sensitivity. They're entering vision for the surgical eye is 20/25, pinhole no improvement, so a little bit blurry. And you need to have a little bit of imagination that you have a stereo view for this fundus photo, but if you did, you would see just a little elevation in the macula, and I think you can appreciate that there's no foveal light reflex there. So this is cystoid macular edema, our good old friend Irvine gas. Incidence is about 0.8%, so again, one of the more common complications, totally treatable in your office, usually going to happen about 6 to 10 weeks after surgery when the patient has finished their post-operative drop regimen. Can be subtle signs on fundoscopy, so if you don't have an OCT, just taking really careful note to compare the symptomatic versus asymptomatic eye for subtle signs on the retina. Any elevation, you might see a little cystoid appearance, cell in the vitreous, telltale sign. Also, remember to do gonio for these patients because tying into the last case, these patients can have retained lens fragments which may need to be washed out. So treatment is standard 4 times a day for your steroid and NSAID. Monitor every 4 to 6 weeks. If you have an OCT, great. As long as you're seeing some improvement at every visit, it's okay to keep going with topical therapy. But if you see a halt in progression of improvement, or if they're just not responding at all, you can certainly send those patients on for a subtenon or intravitreal injection.
I think we kind of know who these people are likely to be. You'll see the notes coming back from the surgeons about an extended drop therapy to avoid circumstances like this. People with retinal issues already, most notably a retinal membrane, diabetics, particularly fragile. diabetics. So we kind of know who these people are going to be before they present. And I suspect the incidence that you have here is mostly just kind of like all comers. But those folks are much, much higher. And we generally will use post-op drops for up to 7 weeks afterwards, in some cases longer, depending on if they're already being managed by retina.
All right, I think we're gonna wrap up there. Anna's gonna start shooting spitballs at us from the crow's nest over here. So
Yep, we'll go ahead and take questions.
yeah, maybe
So-
we'll take a question or two.
Yeah, we've got a few minutes for questions for sure. So go ahead.
I just put my, we can put it back up in a little bit too, but my email up there, if any of you have any questions, I'm always happy to help. You know, sometimes it's you're a little more comfortable peer-to-peer asking questions, versus going straight to one of our surgeons. So I just put my email up there just because I was the one that put the slide together, but I'm sure any of us would be happy to be kind of more of a personal connection to you in our clinics.
Absolutely. I think most
Yeah.
know our, at least my cell phone number. So if you just have a question, just text me, say, what do I do? I think the most important thing is don't panic, but consider all the things.
Yeah, and your outreach representative can get you any of their contact information as well. So if you don't have it and you want it, feel free to reach out to Danelle, Krista, or Kelly for that information. Do you have any questions up there yet? I can't see your screen. Okay, I'm sure we'll give people a few minutes. QR code signs are coming around for COPE as well.
I can take question number 2. Do we increase or start antibiotics for infectious keratitis prior to referral for culture? So preferably yes, just because the patient is already on an antibiotic, so the likelihood of you kind of decreasing the effectivity of our culture is low, and the risk of not increasing the antibiotic is high. So preferably do have them start, especially if there's a little bit of time between when they're in your chair and when they're in our office, just because they can get pretty bad fast.
One thing that I would add though to that is to try to send your notes like immediately, even if they're not complete, with the pertinent information, because sometimes we're waiting for that to kind of know what sort of plan we're going to modify.
Then someone asks, when do you see a choroid detachment back, and what is typical dose of atropine? What is the average length of time that they're on atropine? So usually I prescribe it twice a day, and then I see them back every few days until there's some elevation in the eye pressure or some of the signs of hypotony start to improve. Say the typical dose of atropine is probably like 1 to 6 weeks, depending on how well they respond. Yeah.
And then one more question about cystoid macular edema. So the question is, do you see a preference between Pred Forte and Durezol? So this may be more kind of a patient preference. If they are tolerating 4 times a day for dosage, then Pred is just fine. If they're struggling to get their drops in, or if you think they're having a compliance issue, you could certainly do the Durezol instead.
And our good friend insurance coverage.
I was just
And
going to say.
insurance. I've had one patient ever that had a reasonable copay, but yeah.
Well, thank you so much, you guys. Great presentation. We appreciate it. And as